We are live in 5, 4, 3, 2, 1.
Good
You're live,
evening.
sir.
Good evening, friends and seniors. On behalf of Uttaranchal Orthopaedic Association, I welcome you all in the 6th webinar of the series. I welcome our speaker, the former president of Indian Orthopaedic Association, none other than Professor M. Shantharam Shetty. I welcome you, sir. I welcome our panelists, Professor Alok Chandra Agarwal from AIIMS Raipur. Welcome, sir. Professor Vijendra Chauhan from Himalayan Institute of Medical Sciences, Jollygrant, Uttarakhand. Welcome, sir. Dr. Naresh Chandra from Ghaziabad, the founder of Dynamic Ghaziabad Orthopedic Club. Welcome, sir. And I welcome Dr. Ravi Futela from Rudrapur, the young, energetic past president of Uttaranchal Orthopaedic Association. Welcome, sir. I also welcome Dr. Himanshu Kochar, our dynamic past secretary of Uttaranchal Orthopaedic Association, and Dr. I.M. Singhal, our worthy president of Uttaranchal Orthopaedic Association. Welcome, sir. Now I would request our president, Dr. I.M. Singhal, for a formal welcome address. Dr. I.M. Singhal, sir.
Thank you, Dr. Sirohi sir. And you really deserve all the accolades for your constant and regular endeavor for keeping us all updated. It is really proud that for the whole of the Orthopedic Association to attend this academic feast. And I now welcome, on behalf of Uttaranchal Orthopaedic Association, I welcome the faculty members, the panelists, and our guest speaker, Dr. Shetty Saab, to update us and to enlighten us with all his experiences. I request Dr. Sirohi Saab to please start the session. Over to you, Dr. Sirohi Saab.
Thank you, Dr. Singhal. Though Professor Shantharam Shetty needs no introduction in orthopedic world, but for the benefit of young orthopods and our colleagues from other specialties, I would like to point out few of his credentials. Dr. Shetty graduated from Mysore in 1964 and did his MS in 1970 from Delhi University. He has been professor and head Kasturba Medical College, Mysore for PG students from 1974 to 1998. He has more than 50 years of teaching experience. Few of his instances are Dean, Hajj Medical Academy from 98 to 2007, Vice Chancellor, Nitta University from 2008 to 2012, Pro Chancellor of Nitta University since July 2012. He has more than 380 PG students who have done PG under him and are teaching in various institutions in India and abroad. He has presented 282 scientific papers, delivered 160 CME lectures, and has many more credentials, which will be very long list. At least I can say he has been president of Indian Orthopaedic Association in 2009, and at that time the theme of the IOA was Disability Free India. He has also been associated with AO Trauma and chairman of AO Trauma. I welcome you, Dr. Shetty, and I would request you to please share your screen and start the talk, which is very, very useful one, osteoporosis and osteoporotic fractures.
Thank you.
There have been, sir, many other faculty, other specialty people also that will be attending that talk, because they have especially said that will send the link to us. We will also be attending. So
Sure.
it is a very good topic you have chosen.
Yeah.
I hope all will be benefited.
Sure.
Please, sir.
Okay. Good evening. Good evening, Dr. Ashok, Dr. Singhal, Dr. Naresh, Dr. Alok, Dr. Ravi, Dr. Himanshu, Dr. Chauhan, and all the faculty members and the panelists and the members of the Uttaranchal Orthopaedic Association, which is very vibrant today. It is indeed a pleasure to share a few of my thoughts on this very important subject today, and I will be going on from the medical aspect of it to the surgical aspect of it. I greet you from my own university, Nita University, which is a deemed university for the last 21 years, which is ranked 76th amongst the 542 institutions, universities in the country, and my own hospital, the Tejaswini Hospital, which is a DNB center. What is osteoporosis? By definition, osteoporosis means bone, and porosis, which means porous bone. A progressive systematic skeletal disease, which is characterized by low bone mass and micro-architectural deterioration of the bone tissue as a tissue, with a consequent increase in bone fragility and susceptibility to fracture. That is the correct definition of osteoporosis. But the World Health Organization operationally defines osteoporosis as a bone density that falls minus 0.25 standard deviation below the mean for young healthy adults of the same sex. It is also referred to as T-score of minus 2.5. And a T-score, which is less than up to 1, is low bone density, which is called osteopenia. What are the types of osteoporosis by origin? By origin, it is primary and secondary osteoporosis. Primary osteoporosis is type 1 osteoporosis, which is postmenopausal, very common in ladies, and type 2, which is senile osteoporosis. Whereas secondary osteoporosis is secondary to diseases either due to renal failure or hyperparathyroidism, hormonal, iatrogenic, corticosteroids induced, anticonvulsants, and due to lifestyle, either due to tobacco or alcoholic abuse. And we will deal mainly with the postmenopausal and senile and the lifestyle importance of this osteoporosis. Primary osteoporosis affects 80% of women, as I told you, and 60% of men with osteoporosis. Whereas type 1 osteoporosis may occur in postmenopausal women, usually between the ages of 51 to 75, characterized by accelerated and disproportionate trabecular bone loss and associated with usually vertebral body fractures and distal forearm or distal radius fractures, and which is estrogen withdrawal, which is a estrogen withdrawal effect. Whereas type 2 osteoporosis is involutional, occurs in both men and women aged about 70 years of age, characterized by both trabecular and cortical bone loss, and associated with fractures of the proximal humerus, the proximal tibia, femoral neck fractures, and pelvic fractures. This difference has to be taken into consideration. Laboratory test biochemical profile to evaluate the renal and hepatic function has to be done in this. Primary hyperparathyroidism has to be ruled out, and malnutrition has to be ruled out. CBC for nutritional status and myeloma has to be ruled out. TSZ to rule out the presence of hyperthyroidism, and vitamin D level has to be undertaken, and consideration of 24-hour urine collection of calcium and the excess skeletal loss has to be assessed with vitamin D. Coming to other laboratory tests, biochemical markers today of bone remodeling may be useful to predict the rate of bone loss or follow therapy. When you give up the therapy, you will have to follow what is the response. So specific biochemical markers followed by 3 months interval to document normalization as a separate response to therapy. What is the response to your therapy has to be understood, which we are not doing it before. And number one is high turnover osteoporosis, high levels of resorption markers, and formation markers, which result in accelerated bone loss when there is osteoclastic resorption, responding best to anti-resorptive therapy, whether it's working or not. Whereas low normal turnover osteoporosis is normal or low levels of the markers of resorption and formation. So no accelerated bone loss occurs, responds best to drugs that enhances bone formation. So you'll have to understand the difference between anti-resorptive and which the drugs which enhance bone formation. So, gentlemen, it is pathophysiology of osteoporosis is a balance between bone formation and bone resorption, whether the increased bone resorption and decreased formation of new bone. And that from a balance, it becomes an imbalance. So what happens? The pathophysiology, there is loss of bone mass, there is loss of trabecular plates, as you see. The cortex thickness in senile osteoporosis that becomes thinner, and the contiguity of bone is lost. So there is a structural weakening of the bone per se. Accelerated bone loss occurs in women after menopause because the activity of osteoclasts is enhanced. The osteoclasts make deeper and more numerous resorption lacunae, and the osteoblasts are unable to replace the resorbed bone at the same rate. This process results in net bone loss. Whereas by comparison, the bone loss that occurs with normal aging results from a decrease in osteoblast activity, while osteoclasts retain normal or even slightly decreased activity. Gentlemen, the world population is aging today. What was in 1995, which was just a triangle as you see here, has almost become, in 2025, will almost become almost a rectangle. And the percentage of global population of people aged above 60 years from 1950 to 2050, 1 in 6 will be, mind you, will be in India. 70% of the people live in developing countries in 2050. What was 8%, what was 10%, it will be 21%, and most of them will be from the Afro-Asian countries, which has to be taken into consideration. The dimension of the problem is fracture incidence will increase that by almost 2 to 3-fold due to the aging population. Look at this. Due to insufficient prophylaxis, nothing was done. Patient had a fracture of the trochanteric fracture united. But within 6 months, the patient had a other side fracture, trochanteric fracture. And look at this, after 1.5 years, this patient, though the bone looked fairly all right, not much of osteoporotic, the patient was, the 78-year-old had a fracture on the other side. Similarly, a fracture neck of the femur, which was treated with a cemented bipolar. The other side, within 2.5 years, the patient had 93-year-old lady had a fractured neck of femur. So one fracture leads to almost 2.5-fold risk of future fractures. This has to be taken into consideration by the treating surgeons, you and me. 20% have had fractures of the opposite side in 5 years' time by all the publications hitherto. 26 to 47% risk reduction by anti-resorptive drugs. So if you give anti-resorptive drugs or any other drugs, 26 to 47% the risk reduction takes place. And rates of treatment of osteoporosis is low. In India, it is a rough estimation. It is not with all the coupling with the statistical data. Almost 6% are osteoporotic. You can imagine with a population of 1.3 billion, 6.25 crores, almost 1/5 sustain fractures at least once. And unless these people are treated properly, it can cause an economic stagnation of a developing country like ours. Osteoporosis is treatable. Unfortunately, it is underdiagnosed. And we wake up only when there is a fracture on the other side. Even after that, very little is done. So Galek in osteoporosis way back in 1978-1 have found only 18% of the osteoporotic fracture patients were treated, were put on calcium or vitamin D only, or at the most anti-resorptive drugs, and only 10% had previous treatment. And even the publications of 2010 showed this particular picture. In India, we did a study and published in 2008. In our own study, we found that 35% are put on calcium or vitamin D, nothing else. And supplement, only less than 1% are put on anti-resorptive drugs. This was in 2008. Things have improved considerably now. In a study undertaken by Professor Dr. Balu Sankaran, who was my professor, and we had a combined study upon his postgraduate osteoporosis, and he published a book way back in 2000, Osteoporosis, compiled book. He reported osteoporosis to affect Indian population at an earlier age, nearly a decade before, compared to Caucasians. Caucasians, if they have it in age 70 years, our ladies and men, osteoporosis will be much earlier. What happens in osteoporosis? Is the fracture healing impaired by advanced age, lower number of osteoblasts, decreased activity of osteoblasts, impaired secondary angiogenesis, comorbidity is the root? All are controversial publications. So look at this man, Arnold Schwarzenegger, who was the governor of California. He was Mr. World. It was in 1988. Look at his body, just in about 20 years of time, basking in the sun. That is the change which takes place in the body as all of us age. Fracture risk assessment. Sorry. All over the world today, fracture risk assessment, what is called a FRAX, has developed by WHO to evaluate the fracture risk. It predicts fracture risk by BMD plus clinical risk factors, provides individual absolute risk over a 10-year period, whether this patient is likely to have hip fractures or major osteoporotic fractures. Guidelines regarding when to intervene are also emerging. And the risk factors, the FRAX model, the clinical risk factors are from age to sex to bone, BMD to prior history of fracture, parental history, current smoking, current alcohol, rheumatoid arthritis, and glucose steroids. And the secondary causes are much more. Each clinical risk factor, what is called as the CRF, independently contributes to the fracture probability. So if a patient has any one of these, as per FRAX, there is a more possibility of presence of more than one CRF increases the probability of a fracture incrementally. And in smokers, you see, this is the interesting picture. In India, almost we are much below what is China, where almost 60% smoke, and our men smoke only about 30%. Our ladies smoke only 0%, whereas Norwegians ladies smoke nearly 30%, which is a contributing factor for osteoporosis. As I told you, the intervention threshold by age, and the threshold hip fracture and probability of fracture can be assessed. In most of the developing countries, fracture unfortunately is yet to emerge. In the whole Asian countries, only China has FRAX, and even India, we haven't developed it. Bone mineral density, BMD, using dual X-ray energy absorptiometry, DEXA, is the ideal standard method and indicator for fracture risk today, as we know. And the ultrasound does not have a great say in the matter. Here is the bone mineral density using dual energy X-ray absorptiometry, and is the standard method and indicator of a fracture risk. We must understand, gentlemen, that in osteoporosis in cancellous bone, there is reduction in bone mineral density. Trabeculae are thinned and reduced in number, and the cortex is almost that is a healthy spine, as you see, and the cortical bone is quite strong in a cortical bone with the femur. Whereas that way the bone holding capacity of the implant is reduced when the cancellous bone really crumbles. You see the difference between an osteoporotic spine and an osteoporotic femur. In cortical bone, there is continuous endosteal erosion, more than the periosteal bone formation, and this results in cortex thinning. As you see that slide, in 80 years old, when a screw is fixed, instead of 4 to 5 threads, only 2 threads are engaged and the screws will become loose. As you see, 3 threads instead of 1 thread in an osteoporotic fracture. Coming to management strategies, investigations and treatment principles are the same, whether it's east or west, south or north, or western or eastern. Developed or underdeveloped, principles remain the same, but the philosophy has to change. Before treating fracture, prevention has to be thought of. In a study of the National Osteoporosis Foundation, and it was published, by better care of the elderly, like better environment, hip pads, trivial falls can be prevented, and thereby 50% of the fractures can be prevented. Exercises, Taki, that you see the Chinese the exercising in front of the Tiananmen Square. Various training has increased the bone density. But in India, we just celebrated the Yoga Day just 2 days ago. And yoga is an ideal exercise mode for osteoporosis, which we should advocate in our patients. We advised sunlight, which is abundant from Kashmir to Kanyakumari from almost to Calcutta to Ahmedabad. And the diet with calcium and vitamin D, groundnuts, soya beans, and sardine fish, which is available throughout the country, easily available and affordable to all patients. We are working on this model, and early results are encouraging. And I would advocate simple pranayamas and definitely exercises. I have written a book on orthopedics and yoga, which yoga exercises should be done for an orthopedic patient, especially with osteoporosis. These are the different modes of physical exercises which need not be done but pranayamas, yogas, and simple physical exercises will really bring up the mode of bone density. Coming to drug therapy, the list is long, from hormone therapy to anti-resorptive bisphosphonates. What I have shown in the elbow has stood the test of time, and the PTH, teriparatide, denosumab, and lately the ramusumab. Whereas SERMs and tamoxifen, calcitonin is still given, with, of course, supportive calcium and vitamin D. FDA-approved therapeutic options, as you see here, estrogen is on the other side for the type 1 type of osteoporosis, where the treatment is mainly PTH, teriparatide, and denosumab and ramusumab now, and all the bisphosphonates are in between. Till now, anti-resorptive agents such as bisphosphonates, alendronate, 10 milligrams residronate, of which the most commonly used drug in India is alendronate and residronate. Tablets, bisphosphonates, weekly, monthly, and yearly dosages, and the follow-up is dismal. Our study, we found, as I told you, only 20% of the patients who were advised were taking anti-resorptives continuously. Complications of many are bisphosphonates. You would see the vertebral fractures, resorption of the mandible, subtrochanteric fractures, the changes in the eye, and all these will have to be taken into consideration when bisphosphonates are given. Coming to teriparatide, recombinant human parathyroid hormone is a good drug used for postmenopausal women and with osteoporosis who are at high risk for fracture. It is also used in men with primary or hypogonadal osteoporosis who are at high risk of fracture. And the injection, as all of us know, is 20 micrograms subcutaneously into thigh or abdominal wall. It is used for not more than 18 months. And it may increase the risk of stroke in older women, as reported. There can be abdominal pain. There can be but the risk factors are very much less in teriparatide compared to all other drugs. Delivery device has enough medicine for 28 days. It is set for 20 microgram, as I told you. And the cost factor is about 20,000 per month. And that's about 3 lakhs for the whole treatment. Strontium renylate is orally administered, promotes bone formation by stimulating calcium, and which is not widely used these days. Coming to the newer drug, denosumab, which is a human monoclonal antibody to rankle, which is a good drug, decreases the bone resorption by inhibiting the formation of activity of osteoclasts. That has to be noted. and it is given 60 milligrams subcutaneously every 6 months. And that is a good drug which has to be taken into consideration. And the cost for every 6 months is 1.2 lakhs and is given for a year. The latest drug which has been approved by the FDA as late as 2020, and the pharmaceutical name is the Evenity. This is the newest bone building medication to treat osteoporosis. It is given as an injection every month at your doctor's office. It is limited to 1 year of treatment, followed by other osteoporotic medications. And this is, in short, the medical aspect of osteoporosis. I go into the surgical treatment now. As a surgeon, we are all interested. How do we really treat osteoporotic fractures? The surgical treatment goals are to operate as early as possible, to avoid complications, to prevent secondary fractures, which I mentioned, to correct non-surgical problems, to return to the same quality of life. And what we should understand is that in osteoporotic fractures, we are not just treating the fractures. We have a comminuted fracture with an elderly patient with many superadded problems like diabetes, CV disorders, osteoarthritis, rheumatoid arthritis, and overadded social and economic problems. So most of the patients are neglected and not treated properly, unfortunately, even the world over. And the patient compliance is also very low. So what is important is the principles which I have mentioned in treating these fractures. The problem, as you see here, is very definitive. You look into that bone, which was Petro Regadani's, the bone is just a shell of bone, and to fix this fracture is indeed a challenge. And we are indeed trying to fix an eggshell with a screw. That has to be taken into consideration. So the basic principle to be followed in osteoporotic fracture to get good results in the present scenario is biological fixation. Biological fixation, both mechanical and biological. Use of load-sharing implants like interlocking nails, tension band constructs, LC plates bring about impaction and compression, which enhances stability. That has to be taken into consideration. Use of wide buttress plate. Use tension band devices wherever you can. Long splintage interlocking nails and long plates and lesser screws. Augment with bone cement whenever it is necessary, or with bone grafts. Finally, if you think there is no other option, replacement orthoplasty, mostly in fracture neck of the femur and sometimes even in trochanteric fractures, even sometimes in supracondylar fractures or proximal humerus fractures can be done. No doubt, however, gentlemen, locking plates, anatomical plates today have changed the scenario again, especially in metaphyseal fractures, upper tibial fractures, supracondylar fractures, proximal humerus, which are very common in senile osteoporosis, distal humerus fractures, and distal radius fractures, which is type 1 fractures. And with specialized plates, we can do a good job. Look into the array of anatomical plates which we have today. Vertebroplasty and kyphoplasty have brought in remarkable relief of pain and lessening of spinal deformities, though there are complications envisaged. Augmentation technique, cement delivery system, bone screw with perforations. Newer implant designs have brought about better fixation devices, especially for trochanteric and fracture neck of the femur. Here is a trochanteric fracture with the PFN. You see the the cement delivery system where the cement has been infused and which will give stability to the fracture per se. But in India, Dr. Ashok and Dr. Naresh rightly asked me, what about in India? Yes, we are 1.24 billion people. 10% can afford any type of treatment like you and me. 60% are middle-class families. Half of them cannot afford even LCPs. And 30% are below poverty line. They cannot afford any treatment at all. How to solve this problem? Change the implant design. It is a long, expensive way to go. Use standard implants in a rational way. That is the answer. Load sharing, as I told you, not load bearing. Bringing about splitting. No peak load or stress concentration. Forces are to be equally distributed. Look at this Ilizarov method, with hands off to that great man from Siberia, Ilizarov. He brought out this concept, which can easily be used to bring about compression of the fractures, and tension band devices whenever written, and buttress plates wherever it is possible. Look at this proximal humerus fractures, and this is the 4-part fracture with the extension to the shaft, beautifully operated and fixed to the Philos plate. But at the same time, this is also a 3-part fracture. Just a Sharpie fibers guarantee excellent hold for cerclage wire. This impaction was brought about. You see the displacement of the fracture of the left corner. It has been just with a simple tension band device with the wire. It has been brought back into position. Look at this locking plate for the proximal humerus, beautifully done. The fracture has united. That was the original plate, and this is the latest Philos plate. But we have moved on from there to even to interlocking nails for the 3-part or 4-part fractures. Here you would appreciate the fracture dislocation of the shoulder with the 4-part fracture there, and beautifully operated with a locking nail, which has come into being now. And this is a picture this is the saga of different types of nails which were used for the fractured humerus and the proximal humerus as well. And today we have gone into evolution into a multi-lock nail. Today we have multi-lock nails for humerus, which gives both stability and ability. You would appreciate the multi-lock nail, which is no doubt it is very costly, but you see the multi-lock in a multi-directional phase, the screws which are placed and screw inside the screw. And this is you appreciate that fracture, which is a fracture dislocation again, which was treated by a multi-lock nail. And that is the picture which you see there with a classical multi-lock nail in position, where the fracture has been reduced so well and the screw in perfect position. Whereas this is a simple method which I did, the Indian method which I showed you. This is the 4-part fracture, and the cost of Philos or multi-lock nail is nearly 40,000. This is 25,000 at Philos, where the cost of a tension band is rupees 500, and that fracture was treated with a tension band device as you see, and the fracture unites well, and that is the functional limit. Lower humerus fracture is elderly, is a real problem. It's a bag of bones many a times. We have locking plates of different devices with a plate, as you see the middle plate, which is the plate which is used today, with either parallel plate or 90-90 plate. Here is a non-union in an elderly osteoporotic patient, beautifully where compression has been brought out with a simple plate device. With the bone grafting, the fracture is united with good functional range. Whereas this fracture, it was just a bag of bone, as you see here, and we went in. It was a bag of bone, but with the tension band device, all those fractures could be fixed, and the fracture united with a fairly good functional range. Lower end of the radius is a problem even today, all over the country, and many publications have come out. About 65 years with osteoporosis, is better to treat them conservatively, but still it depends on the type of fracture and if it is a molar bottom which is completely displaced or multifragmentary, it has to be treated with the plate. And the multi-lock plates have come into vogue, which is multi-directional, which gives excellent results, as you see in that particular picture. And or simple, if it is a device in younger patients, of course the KYs can be. But I'm just putting this X-ray, and I put this X-ray in one of the hand conferences. Everybody said it has to be operated because it is a badly displaced fracture in an elderly patient, both the styloid process of the ulna and the chunk of bone of the radius. And we reduced that fracture conservatively, and this was the picture after reduction. And all the modalities which you see there, the fracture unites beautifully in 8 weeks' time. And 12 months review, you see almost all the lines. The radial inclination is 20 degrees, tilt is 10 degrees, length is 10 millimeters, and the articular step is less than 1 millimeter. And it is even the inferior joint is quite stable. and that is the functional brace. So conservative treatment has a role to play in osteoporosis, and it is the selection of the surgeon which is important. We come to the important fraction neck of the femur and the trochanteric fractures. And all of us know cannulated screw is the test of time, is the well-tested treatment for well-reduced fractures. But you can choose a hemiarthroplasty, and ideally is to do a hemiarthroplasty with the cemented bipolar prosthesis. And here into the trochanteric fractures, the options are DHS, different types of intramedullary devices like gamma nails, PFN. However, endoprosthesis is sought with more complications. Here is the DHS, which is perfectly done. Here is the interlock and the PFN, which is done with it. And here I will appreciate the PFN still remain, whether the long PFN, the short PFN is a debatable, but this is an ideal situation for an elderly patient. I'm just putting you this X-ray, the importance of, here is the 88-year-old female. She had a domestic fall, housebound, ambulatory, without support, known diabetic, and hypertension, medications, underwent scapulomedullary nailing 7 years back, and she came with this picture. She had a perinatal fracture there and a comminuted shatter fracture of the distal humerus, and no complaints with the limb. And she was COVID positive. This was just done during the COVID time. And we fixed with this particular plate, as you see, the extension onto the lateral condyle, and fixed with a longer nail. And this was the nail which was. She was discharged, and after that she came. The pain, there was history of pain at both sides. She comes back with this particular picture. She had a trivial fall again. She broke both the fractures, and that is the picture. What would you do? She was still COVID positive, and we thought we'll try teriparatide because she refused surgery. Luckily for us and for her, and we just give a functional brace both for the humerus and both for the femur, and put her on teriparatide. And this was put on as you see, a functional brace was put, teriparatide, after consultation with the endocrinologist. Look at this picture after 4 months. We couldn't believe that the distal femur, so much of callus has formed, whether it is attributed to teriparatide or we do not know, but this has happened. So even the distal humerus has united. Look at this osteoporotic fracture with the classically done with the PFN with the perfection. And look at this, all these periplate fractures in an elderly. What is important is to bring about union at the fracture site with a compression. And this is a 1 year follow-up of that. Here is a unipolar, whether it is, today it is a bipolar with a cement is ideal, or a total lip if the patient is really good physically and by bone wise. Here is a 75-year-old. This was the type of nailing the patient came to us, and this was at least primum non-noise array. What was done is to bring about compression with the plating, as you see there, and the fracture unites in 32 weeks time. Here is what would you do in a fracture of this nature? The patient had a DHS many years ago. She comes with a periplate fracture, as you see there. We tried to remove the hip screw. It was not possible. What would you do? It is not. Many times, all of you seniors would understand that is almost impossible to remove the screw many times if it is more than 10 years. And this was more than 15 years. And we had to innovate. What we did was, we could not remove that. We removed just the screws. So we put a nail from below, from the knee, and made holes, separate holes, sent it to the workshop, separate holes so that it can be locked higher up. And this was the picture, and finally the fracture unites. So in osteoporosis, many times you'll have to innovate. Here is a classical picture of an osteoporotic fracture. This is not the classical plate, but if you bring about good reduction and compression at the fracture site, the fracture will unite. Or if this is a better way, in an elderly, put for a distal femur with a nail in situ brings about good callus. Gentlemen, ideal situation in osteoporotic fractures is not pin and plasters are not just good enough many times. A call for treatment for osteoporotic fractures by Italian stores way back in 2008. Efforts have to be concentrated on prevention of osteoporosis, all of us, and thereby fracture prevention, at least to the other side of further fracture, so that our elderly all over the world are saved from the agony of osteoporosis and related osteoporotic fractures. Basic mechanical and biological aspects and internal fixation of fractures can never be eclipsed by new fixation devices. Whatever may be your anatomical plates, but it does not work unless inferior surgical handicrafts is even more unforgiving in osteoporotic bone than in normal bone. That has to be. Osteoporotic fractures always unite if you bring about a biomechanical action. So surgeon should be a gardener and not a carpenter. To conclude, in osteoporosis worldwide, threat is a reality. It has to be faced with vigor, and an interdisciplinary approach has to be undertaken. We have to take an endocrinologist, we have to take a physiotherapist, we have to take everybody into even a psychiatrist. Be innovative and use God-given sunlight, food supplements like groundnut, fish and milk and yoga to prevent osteoporotic fractures. Anti-resorptives are still the mainstay of medical therapy, even today all around the world, but long-term therapy can cause complications, as I have mentioned. PTH, teriparatide, denosumab, romosozumab have opened new vistas for medical treatment for osteoporosis. Gene therapy and stem cell therapy are proving new horizons and hope for osteoporosis. As surgeons, with the advent of newer plates and nails, fixation of osteoporotic fractures have become much easier world over. But in developing countries like India, with the same basic principles of tension band, buttressing, and impaction of fracture site, with innovations, can bring about fairly good results in our patients. So thank you very much indeed. And I will just show you one example of what is the example of what is this fracture. Just to save time, this patient was under treatment of a neurologist for nearly 1 year, thinking it was a dystrophy, and he was completely bedridden. And all that we did was to do a serum calcium and an alkaline phosphatase, seeing the thinning of the cortex and the fracture there. We thought it was hyperparathyroidism. We were right when we took the skeletal survey. There was a large lytic lesion in the proximal femur. See the osteoporotic nature of the bone, and that was the lytic lesion of the thing. And you see the resorption of the terminal phalanx, especially of the ring finger, and that is the chest X-ray which shows multiple fractures there, and that is the typical pepper pot appearance of the skull with the absence of lamina dura in the teeth. All classical radiological pictures of a hyperparathyroidism. All that we did was get a CT of the neck, and there was a large, as you see, a large hyperthyroid adenoma, and we operated and removed the adenoma, and that was the final picture. You would appreciate, without any surgical intervention or anything, the fracture has united very well, and that was the picture. That's fine. Yeah, just put the thank you. Yeah, thank you very much. If there are any questions, we can discuss as you. Yeah.
Thank you, sir. Thank you very much.
Thank you.
And thanks for the nice talk. And I think there must be many questions. First, if there are some audience questions, I would like to ask Dr. Puneet. If there are any audience questions, you may please.
Sir, what is the importance of serum calcium in diagnosis the osteoporosis, sir?
Oh, serum calcium.
Is there any importance of serum calcium?
Oh, serum calcium will be usually low, but it is not diagnostic. It cannot be taken as a diagnosis. Phosphorus also has to be taken. Vitamin D estimation is an important usually in osteoporosis.
So what is your algorithm to use this injection teriparatide? Because sometimes I'm using injection teriparatide, and after a few months I will shift the patient on the denosumab. Is it okay, or we should be
So
consistent
it is
with
always
that?
better to complete the whole treatment for it. So teriparatide once you have started. And after that, if there is still your PMD is low, then the bone mineral density is low, then you will have to think of switching off to denosumab or denosumab.
So ideally, we should switch over him patient after 18-month completion
Yes,
of.
ideally that.
Ideally, it should be.
Sir, I have a question. Yeah. Dr. Sirohi, can I ask a question?
Yeah.
Yes, sir.
I think it's a common question which every orthopedic surgeon would like to understand. So first of all, let me compliment you for coining the word that surgeon should be a gardener and not a carpenter. Really, this profession, we all need to be gardener, and especially in osteoporosis. I have a small question. What should be the protocol of taking osteoporotic medicines in a stepwise manner? Is there any protocol which we all need to adhere to? Because there are a lot of options available. How one should go about choosing these options?
So if the patient, as per the Indian, with our Indian standards, because denosumab is quite costly, it is not available everywhere, but it can afford. So ideally is to start on teriparatide as I see for 18 months if the patient can afford. The patient cannot afford at all, then the bisphosphonate. The problem with bisphosphonate is the complications they have shown very clearly. The subhepatic fractures which itself. We had a CT clearly about 8 cases of subhepatic fractures treated in the long term for the last nearly about 15 years. The subhepatic fracture, which is a difficult problem to treat when they transplant. And the resorption of the mandible and the eye changes all can take place with this option. But there is no other way that the best drug available as an alternative to teriparatide. But I would advise teriparatide as the best drug to be given today.
Sir,
with of course calcium and vitamin D supplements.
yes, Dr. Naresh, please. Please unmute yourself, sir. Dr. Naresh, unmute yourself.
I think you can. I'm audible now.
Yes, yes.
Yes, yes.
So there are a few differences because I'm not an expert or even then.
Yeah.
Starting from the first question, the role of the calcium estimation. Calcium estimation in cases of this, calcium level is not the diagnostic for the osteoporosis.
Yes.
But calcium level is important. Either you start the biphosphonate or you start the teriparatide. If you want to start the biphosphonate, if there is hypocalcemia, this is one of the main contraindication of starting the biphosphonate. And if there is hypercalcemia, that is a major contraindication to start that teriparatide. Because in these cases, many times you will find the secondary hyperparathyroid because of the deficiency of the vitamin D. You will find very low vitamin D, high calcium, high PTH will be very high. These three investigations are must. Until we bring the PTH down, we can never give the teriparatide. And but I think personally, sir, that there is a special recommendation for starting the paratide. T score not below the minus 3.5. There is an indication for the teriparatide. That's what I've read, sir.
No, that's it. We went through the whole this thing. Now, instead of the calcium estimation as such, it is the biochemical markers which are required. Biochemical markers which I have mentioned. It is done in almost every other lab today. The biochemical markers will tell you whether what drug you are giving is really working or not. But before starting either teriparatide or bisphosphonate, as you said, it will give an indication, but it is not a definitive indication that this can be done. When you have started the therapy, you will know whether it can result in hypercalciuria or hypercalcemia, and that has to be taken. That can be biochemical markers can give a very definite idea whether the bone is resolving or whether the bone is forming. These biomarkers are a definitive indication of bone formation or bone resorption.
Is it clear, sir?
Pardon?
Yeah.
No,
Sir,
but I personally think even then,
that's right. No, that's we used to depend, as they rightly said, the serum calcium and phosphorus was done. Even vitamin D estimation was to be done.
because I personally think even the drug,
because many of these patients can hypercalcemia and can result as a secondary hyperthyroidism, even tertiary hyperthyroidism at the later stage. That was a well-known phenomenon.
but what I mean is even today the first option is biphosphonates.
Yeah.
First option is biphosphonates.
No,
Now the question,
bisphosphonate
biphosphonate is the first option. Even now the biphosphonate is the first option. That depends whether you want to give daily, you want to give weekly, monthly, or yearly.
that's right.
That is a different thing.
Problem
Or,
is
now about the denizenib, it is a as you told you, sir, just now you told you, it is a monoclonal antibody.
Yeah.
And the main side effect is infection, eczema, and
That's-
cost.
I know the cost factor is, but it is
Cost is also, but it is antibody. It is a prone to develop the infection.
monoclonal antibody to rankle. It is given for the state name is as you know, it's the Prolia, and it is given every 6 months. So what 60 milligrams subcutaneously for 3 years. So the cost factor is a very important thing, but it acts as an osteoclastic resorption is contained. Whereas the romosozumab which has come in, both acts as a spirostin inhibitor. So it both as the osteoclastic resorption and the osteoclastic proliferation that takes place. Osteoclastic proliferation takes place, and the osteoclastic resorption also is important.
But my question for the sake of the delegates, is there a role of the combined therapy? Biphosphonate, even that way I want to say biphosphonate along with the teriparatide, and what should the protocol? There is,
No, that's why before you start any treatment, you need to know the baseline blood level. That is the investigations of serum calcium, as you rightly said, serum phosphorus, and PTH, and alkaline phosphatase. And unless these baseline investigations are done, you cannot proceed with any drug of your choice. Once you know these are, then you will have to really go over after the treatment what will happen, because your EMD cannot be repeated only after 1 year. It can be repeated again.
Sir, I have one more question.
Yes.
That in deciding whether to choose alendronates or to choose zoledronic acid, what are the criteria to use both of them?
So alendronate is to be given as tablets daily, but the zoledronic, the greatest advantage is it is given the 6 monthly or a year. That's the greatest advantage, and it has almost the same effects. We use zoledronic acid rather than alendronate.
But
Sir,
is there
can
a
I-
period? Yeah, I'll just complete it. Is there a window period where we need to, after giving for a particular duration, we need to stop it? Because alendronate, you can continue till 5 years, whereas, and then you need to do the risk assessment. Whereas for zoledronic acid, the risk assessment needs to be done on a 33-year basis.
Yeah, that's right. That is the only difference, because even alendronate you will have to assess after 3 years. You can go up to 5 years, and after the 5 years you will have to monitor to be used and see the monitor the treatment. So it can be given up to 7 years if it is risky, but not more than 7 years. Then you will have to you may have to change it. You may have to change to teriparatide or any other type of choice.
Thank you, sir.
But sir,
Sir.
can I speak, Dr. Sirohi?
Yes, sir, yes.
Now the biological
you see, if you are giving the biphosphonates and you want to give the teriparatide, there will be blunting of the effect. You will have to give minimum 6 months time.
That's right. You will have to only
6
after
months
5
minimum
years.
time.
After 5
But
years,
when you give the teriparatide, and you can immediately should go to the anti-resorptive like alendronate. Otherwise, you lose the effect of the teriparatide. But vice versa, it is not.
See, both are contradictory to each other. One is a bone forming drug, one is a bone resorbing. So that has to be taken into account.
Yes.
Sir, can I ask 2-3
Yeah,
questions?
yes,
It is a nice, interesting thing. Sir, my question is that how do you manage osteoporosis in a renal patient and in patients who have ankylosing spondylitis? So these are two subgroups where there are different kind of management for the osteoporosis. Can you throw a light on that?
No, any comorbid condition, the basic
Especially,
investigation.
sir, renal patients where the PTH is high, where there is already osteodystrophy because of the both.
That's why the basic, even in a renal patient, if you the baseline blood investigations, as I told you, serum calcium, serum phosphorus, serum alkaline phosphatase, and even your PTH, parathormone hormone has to be undertaken. If it is abnormal, you shall not start the treatment, and the renal function will have to be assessed. That has to be rectified before we start.
And sir, in patients with angspon, though they have there is an anthesiopathy and there is an overlying bone formation of the ligaments, but even then they suffer from osteoporosis because of the inflammatory process. So how do you take that in the consideration?
The usual ankylosing spondylitis is osteoporosis when the patient is not able to move, is lack of exercise. It is a disease, just like a fracture disease, atrophy of bone. So they lead to that. That there is a separate different entity altogether. So your peripartite or your this will not be of great help, but activity is important in ankylosing spondylitis.
Thank you, sir.
Sir, what is the ideal duration to give the injection denosumab, because I am very frequently using it, and it is nowadays very cost effective, below 20,000 it is available, and a very good compliance with the patient, sir.
5 to 10 years.
Denosumab is 3 years. 3 years.
3 years.
So 5 to 10 years it is recommended, so it can be given. Once you stop denosumab, the effect weans off.
Yeah, that's
so
that danger is there. You will have to, after 3 years, their recommendation is 3 years, but immediately you will have to assess the patient.
Yes,
you have to assess that.
True, but there are studies.
They can suddenly go into resorption of the bone. The problem is that after the time it can osteoclastic resorption, it has control. Suddenly it triggers off with the osteoclastic resorption coming back in a big way. That can cause calamity. So you'll have to.
Sir, have you ever encountered an atypical fracture because of the bisphosphonates? And can you throw a light on the management of atypical fractures?
This is, I had a series of, I have, as I told you, we have presented that this thing is atypical fracture. When a fracture-based patient comes with a subtrochanteric fracture, with a hairline fracture there in the subtrochanteric region. If you leave it alone, the patient will come with a complete. That is the time immediately after the nailing has to be done. It is easy to just put in a nail, just push in a nail, because it is just a hairline fracture in one of the parts. Otherwise, the patient with a trivial fall will have a short oblique fracture with a direct subtrochanteric fracture in this part.
Sir, is there any role of...
Yes, sir.
We had a classical example of such a fracture, where the patient came with a hairline fracture like that, and we advised the surgery, she refused, and within 3 months she came back to the complete form. And at that time the other side also had a hairline, so we had to operate on both the.
So main thing is, sir, that if we have a fracture on one side, we should always be look out for fracture on the other side and prevent the other side.
Yes, it has to be.
That message should go very clearly to all the audience.
Dr.
Yes, sir. Yes, sir.
The atypical femoral fracture are extremely rare. The report says it is 5.9 in 10 lakh, 1 million. And the osteonecrosis of jaw only of the 2 in the 10 lakh. It's extremely rare. But there are 2 complications of biphosphonates, but they are extremely rare.
No, the bisphosphonates, we ourselves had a large. If you look at the Singapore people, they were the first people to publish on subtrochanteric fractures related to bisphosphonates, and they have a fairly large series and they were the first to waken up the whole world on the subtraumatic fracture, which is as a complication, and it is unfortunately it is underreported. That is the problem.
Maybe, sir. You are right, sir. You are right. Sir,
So you recommended bisphosphonates for 2 years, sir, or more?
No, it can
bisphosphonates, sir.
It is up to 5 years, sir.
5 years.
Not for 2 years. 5 years.
5 years.
In extreme cases, up to 10 years even.
Even 7 years.
Sir, may I ask one question, sir?
Yes, sir.
What is the status?
Yes, sir.
If in the post-menopausal woman, the VMD is minus 1.5, minus 2 to minus 2.5, severe osteopenia. Then what we should do?
Severe osteopenia with calcium and vitamin D with all the supportive treatment. See for some time, and if it is not, then it has to be holistic approach has to be taken into account. All is the holistic approach: exercises, with sunlight, with good nutrition, with preventive measures, and see whether calcium and vitamin D, no anti-resorptive as such, or and breathe again and see whether they improve.
No hormonal therapy, sir, for postmenopausal?
Hormone therapy has, because of the complications which are involved.
It is called.
Involved with breast cancer and other problems. They are very. It was evident. It was in a large scale for 2 big.
Dr. Alok, sir, would you like to ask something?
Sir, is there any role of injection teriparatide in fracture healing, sir?
Yes, it is. Many times we have found it. See, many of these people we have found even between 45 to 55 years of age, where it has it is a small group of study where surgeons have reported.
Sir, even in the cases which are not osteoporotic, is it recommended to give teriparatide?
For some reason, if you feel that this fracture is likely to give trouble, then it is worthwhile trying a teriparatide. It has helped in that. And as the Dr. Naresh was rightly telling, if it is osteopenic, then it is really worth it in a fracture giving teriparatide. But not as a routine in younger patients with a teriparatide as such.
Dr. Naresh, do you also have same opinion?
No, even in a younger patient, as it may overkill the natural response of the patient. In a young patient, the fracture has to unite if the proper biomechanical aspects of a fracture healing has been taken into account, both the biology and the mechanical aspect. If you have then the fracture has to unite well in a normal.
In younger patients, the teriparatide should not be given.
So it is not necessary. You are overkilling it.
Okay, that's clear.
And sometimes for unknown reasons, if it has gone into non-unit, or you think it is a delayed unit, after in 5 or 6 months time, the fracture not growing callus as it should. You can try as a teriparatide as a problem.
Okay.
Ruling out all other problems. Why the fracture has gone.
Sir, I'd like to make one comment. Can I speak, Dr. Sirohi?
Yes, sir, and you are not visible, sir.
So I don't know. I'm trying to come on the screen, but they are not permitting me to come on the screen.
Dr. Ashok Shyam, please permit him.
Because I'm trying to come, but it's saying.
Sir, maybe your camera may be off.
No, my camera is on.
Now you are visible now, sir.
Yes. You see, yeah. Thank you, Dr. Sirohi. You see, majority of the time, when we get patient we always go for only for simple investigation, densitometry. I would request everybody, just please don't rely purely on densitometry. Densitometry is only a tool. We also need to rely on our good clinical history. The age of the patient, whether he's taking steroids, whether he's smoking. I think these all important factors also play a very major role. We need to take care of them. We should not only treat bone densitometries.
That's right. That's a very well taken. The patient has to be taken as a whole.
Yes.
Not the fraction.
Dr. Futela, please unmute yourself before speaking. Yes.
Sir, it was a very informative lecture. I'm very thankful to Dr. Shetty. In the last case, you have shown that the fracture united up after giving teriparatide. Do you recommend teriparatide treatment for all delayed union in elderly patients?
No, if you find that you are biomechanically you are poor, there is some reason for non-use. And there is problems in reoperating on that particular patient, or there is some problem related to the particular teriparatide combined, and we have tried it. We have been successful in the majority of cases. It can be as an adjuvant. It can be.
So he is asking for the elderly, all elderly patients.
Not as a routine. And remember that patient which I have shown was a COVID patient which we operated.
Is there any study, sir? Is there any study showing any data regarding the union rate after giving teriparatide?
Yes,
delayed unions and non-unions.
They have found that delayed union, non-union teriparatide has helped. I do not have the ready reckoner of this. You can just click on the Google, you will get it.
Yeah. Okay, sir. Thank you, sir. Thank you.
So, yes, Dr. Alok, please.
Actually, it was a pleasure listening to Dr. Shantharam Shetty like always. And he was at his best performance today. The questions which are going bring about two things which Dr. Shantharam Shetty clearly told. One was recognizing a high turnover osteoporosis from a low turnover osteoporosis, and that will decide the treatment. Second thing, there is the concept of making the bone metabolically active. It's not just giving for 10 years biphosphonates or giving osteoblastic activity. But there is definitely a role at times for AIIMS method. In first, you give an osteoblastic activity by teriparatide for a month. Then you give biphosphonates for a month. Then you give a drug-free interval of 1 month, and then you repeat the cycles. And we have done this AIIMS method also in many of the patients, and I found to be very good. So these were the things which were remaining in today's discussion. So I wanted to bring it them to the highlight. Thank you, Dr. Shantharam.
So you want to say 1 month teriparatide, then the other month bisphosphonate, or longer period?
It's given in all standard textbooks also with a very good results.
Now, as Dr. Alok rightly said, the biochemical markers will give you an idea whether what is happening. So it can be, if you started on bisphosphonates and then the biochemical markers say when you are doing the right thing, you go ahead and do that.
You can open the standard textbook of Raipur in green, the chapter on osteoporosis. There also it is mentioned. They have been trying it. So the question is of making the bone metabolically active. It is a living tissue with wear and tear. So it will be active, it will be strong. And high turnover and low turnover with the markers. This is a very important point brought about only today by Dr. Shantharam Shetty. Till now nobody was discussing it. So now we will practice that also. Thank you.
That's good. That's good.
Thank you, sir. So I think if anything else is not needed, sir, would you like to discuss some things about the surgical points also?
surgical.
Or you think that the nails are better for the aged people than the...
As I rightly told you, the osteoporotic, the misconception is that the osteoporotic fracture there will be a delayed union or non-union. No, osteoporotic fractures always heal as a normal bone.
Yes.
Given the proper biomechanical support. So you will have to, instead of using plates where it is likely to become loose or a plate which is not meant for that particular fracture, it is better to use the intramedullary device as I told you, or a tension band device as I told you, or even a Elizaro as I told you. So it is an alternative, especially in our country. It is really the price tag is much less, and you can also the patient's compliance is also very important, especially in the area.
Actually, I wanted to ask you one thing. That when you are using a fracture net femur and you are putting an implant, how do you introduce cement? And then 20 grams of cement becomes too much and costly. Is there any other way, or are you using some dental material into it?
No, the stem cell can be there. They have started trying, but that also becomes almost equally costly, because you will have to centrifuge it. You will have to have a centrifuge, and you will have to you will have to either a binder to be put into that, like collagen or any other binder. That almost the cost wise it becomes quite costly for the patient. So cement is easily available. Just push it. If the implant allows it to be pushed in, it can easily be pushed in and saves a lot.
People are using more and more
TFN, which has come into the market, the TFN, rotatic femoral nail, which has it's a new implant by Striker, which has holes where cement can be injected.
Sir, what is your experience with using your hydroxyapatite screws?
No, hydroxyapatite screws also, just like what was used in the totally replaced screws and the hydroxyapatite. It has a binding force.
Yes.
Again, the cost factor also, and the screws, unless it is fixed well, whether it is hydroxyapatite coated or not, the principle is more important than the hydroxyapatite.
Dr. Naresh, sir, anything left?
I think completed, very nicely completed, sir. आज बहुत अच्छा लगा सर, आज really.
Nice seeing you. I still remember my visit to Ghaziabad, and you were so.
Please, sir, I will wait.
So, Dr. Sirohi, sir,
Come to Mangalore.
So,
from Uttarakhand, we will invite you to Mangalore. Mangalore is a nice place to see from Uttarakhand. We are on the sea.
Yes, sir, we have been there in the conferences twice.
Alok comes quite often, so all of you come sometime.
Yeah.
Thank you, sir. Thank you for the invitation, sir. So, from my side, sir, I am very thankful to all of you, sir. And for the formal vote of thanks, I will invite our Secretary, Dr. Puneet Agarwal, for the formal vote of thanks from Uttarakhand Orthopaedic Association.
yeah, so there is no more question from the audience. So I would like to thank Dr. Shantharam, sir. It was a really very nice, informative topic for all of us. Thank you, sir. Thanks a lot on behalf of our association. Thanks to Dr. Naresh, sir, Dr. Alok, sir, Dr. Vijendra, sir, Dr. Ravi, sir, Dr. Himanshu, sir, Ortho TV team, and all audience. Thanks a lot, sir.
Thank you very much. Thank you very much.
Thank you, sir.
Thank you.
Thank you, Dr. Sirohi and Puneet and the whole team for organizing it.
Thank you, sir.
Yeah,
It was a pleasure.
It was a pleasure. Yeah.
Thank you, sir, and
everybody.
thank you,
Thank you, sir.
Uttarakhand.
Bye-bye. Bye-bye.
Okay. Thank you, sir. Thank you.
Namaskar.
Namaskar.